Hello, my name is Marco Nievo, and I'm the CSO of CTF Europe. I wanted to welcome you to this info masterclass, and most especially thank you on behalf of all the patients for your interest in NF. Now, before we move on to the real stuff, I need to give you some instructions regarding the Q&A. You will be able to put down your questions by using the chat box during the masterclass. We would much prefer if you put down these questions in English. If you have trouble formulating your question in English, we could advise you to try to use online translators such as Google Translate before putting them down in the chat box. And if that is not possible for you, please do it in your own language, and we will do our best on our end to have it translated as best as we can into English. Enjoy your masterclass.
Hello, my name is Erik Legus. I'm a professor of human genetics at University Hospital of Leuven in Belgium. I will introduce in the first set of this presentation the Nf1 biology and its relation to bone and some bone abnormalities, followed by Professor Christophe Glorion, who is going to deal mainly with the treatment options. Orthopedic Problems in Neurofibromatosis Type 1 by Professor Christophe Glorion and Professor Erik Legus. It is estimated that 30% of Nf1 individuals have skeletal abnormalities ranging from osteopenia over tibial dysplasia and pseudoarthrosis of tibia, fibula, clavicula, or ulna towards a severe scoliosis. Both the NIH consensus criteria of 1987 and the revised criteria have bone lesions as one of the diagnostic criteria. As you can see here in the revised diagnostic criteria of 2021, distinct osseous lesions such as sphenoid dysplasia, anterolateral bowing of the tibia, or pseudoarthrosis of a long bone qualify for a diagnostic criterion. There is one remark that sphenoid wing dysplasia is not a separate criterion in case of an ipsilateral orbital plexiform neurofibroma. This slide shows an orbital plexiform neurofibroma in association with an ipsilateral sphenoid wing dysplasia as an isolated feature not related to neurofibromatosis type 1 because no Nf1 mutation was detected in peripheral white blood cells and there were no other Nf1 related signs or symptoms present. Here we see congenital tibial and fibular bowing of one leg, the left leg. Here we see a pseudoarthrosis that developed after fracture of the tibia and the fibula. Here we see an ulnar pseudoarthrosis, and here you see a sphenoid wing dysplasia. In the next slides, we will discuss Nf1 biology and bone abnormalities. The Nf1 gene is known to be a tumor suppressor gene, meaning that in tumors that form in neurofibromatosis type 1 individuals and that are related to the neurofibromatosis type 1, we find a second hit, a second pathogenic variant in the normal copy of the Nf1 gene. This has been shown in all the different types of neurofibromas, gliomas, gastrointestinal stromal tumors, and so on in neurofibromatosis type 1, but surprisingly also non-tumoral features can be associated with the biallelic inactivation of the Nf1 gene. And this has been shown in congenital bowing of the bones with or without pseudoarthrosis and in dystrophic scoliosis tissue from Nf1 individuals and also in the café spots. It is known that a biallelic inactivation of the Nf1 gene leads to an increased RAS-MAP kinase signaling. Here we see a schematic of the RAS-MAP kinase pathway with the cell membrane and the growth factor receptor inserted in a cell membrane. If it binds to a growth factor, it will dimerize, activate its adapter proteins, and they will then activate RAS by the transition of RAS GTP to RAS GTP. So from GTP to GTP, which is the active form of RAS, which can now bind to RAF and activate MEK and ERG. When activated ERG, phosphorylated ERG, enters the cell nucleus, it will activate transcription of RAS MAP kinase dependent genes. Neurofibromin is a negative regulator because it is a RAS GTPase activating protein, and it will stimulate the transition of RAS GTP to RAS GTP, and therefore inactivate this pathway and insert a brake on this pathway. When this brake is absent, you will have too much single transduction through this pathway. Research on tissue from tibial pseudarthrosis and also from tissue of dystrophic scoliosis has shown a second hit in the Nf1 gene, pointing towards a biallelic inactivation of the Nf1 gene in this tissue with an increased RAS MAP kinase signaling as a result. Research from our own group has shown that the biallelic inactivation of the Nf1 gene is not only limited to the pseudarthrotic tissue here in this place, but it is dispersed over the tibia and can also be found in periosteal tissue here, proximal and distal from the pseudarthrosis side, meaning that the Nf1 second hit originated somewhere during evolution in the lower limb and is then distributed over the tibia. But the pseudarthrosis usually develops at this site here, where the bowing is most severe, and this points towards local factors that poses some stress on this region that in combination with the Nf1 second hit causes the bowing and the pseudarthrosis. So the second hit in the Nf1 gene in itself is not sufficient to cause a pseudarthrosis, and some additional local factors have to be present to get the pseudarthrosis here at this site. There is an influence of plexiform neurofibroma on the overlying adjacent bone. And paraspinal neurofibromas are frequently associated with an increased risk of scoliosis, and the odds is 6 times higher. And in 63% of dystrophic scoliosis, there is a paraspinal neurofibroma associated with it, showing the influence of a neurofibroma on the adjacent bone. The research group of Florent Eleftheriou showed in 2014 in a mouse model that osteoprogenitor cells with a biallelic inactivation of Nf1 showed a MEK-dependent activation of genes promoting the accumulation of inorganic pyrophosphate, and this results in inhibition of bone mineralization. Now, recently, they investigated neurofibromas overlying bone abnormalities, both in the mouse model and in humans, and they could show that these neurofibromas also have loss of the Nf1 gene activity, and that this results also in an activation of genes promoting accumulation of inorganic pyrophosphate, and that this also results in inhibition of bone mineralization. So they found a mechanism by which neurofibroma-associated skeletal manifestations in Nf1 can be explained. On this slide, you see a progressive spinal thoracal scoliosis in a 13-year-old individual. And this scoliosis is associated with a paraspinal plexiform neurofibroma, as was discussed previously. And here you see the 3D reconstruction of the CT scan of the vertebral bodies. Here you see a plexiform neurofibroma of the left hip, gluteus, and upper femoral region. And this plexiform neurofibroma was treated for 12 months with a MEK inhibitor. And here you see the beneficial effect of the MEK inhibitor treatment on the size of the plexiform neurofibroma. On the other hand, they also measured bone mineral density of the total hip and the femoral neck of that side and compared it with controls. And they saw a largely increased bone mineral density after 12 months of MEK inhibitor treatment. And here they looked at the difference between left and right pre-MEK inhibitor treatment compared to controls. And so the left leg showed a lower bone mineral density. And here this discrepancy, this difference between left and right is much less pronounced, showing the beneficial effect of the MEK inhibitor treatment both on the plexiform neurofibroma and on the bone mineral density of the overlying bony structures. A plexiform neurofibroma of a limb can also be associated with overgrowth. Here we see a plexiform neurofibroma affecting the left lower limb from the tibia towards the foot. And here you see the difference in size between the diameter of the right leg and of the left leg. And on this image here, you see that there is an overgrowth of the tibia left compared to the right side. Now we will discuss the presence of non-ossifying fibromas in children with neurofibromatosis type 1. The combination of multiple KFLS spots and multiple non-ossifying fibromas has in the past been reported as Jaffe-Campanacci syndrome. But the publication shown here in Genetics in Medicine pointed out that most of these cases had the heterozygous inactivating variant in the Nf1 gene and are in fact cases of neurofibromatosis type 1. In the lower part of the slide here, you see an example of a non-ossifying fibroma that led to a pathological fracture. And when a pathological fracture occurs, the cystic material is usually cleared by curettage and is filled with bone grafts, and then the fracture is stabilized with osteosynthesis. And here you see the result after removing of the osteosynthesis material and the healing of the bone. When there is no pathological fracture, most of these non-ossifying fibromas have a tendency to heal spontaneously over time after the growth spurt has ceased. These non-ossifying fibromas are very frequently located in the distal femur and in the proximal tibia and are closely associated with the growth plate, as you can see here. Another benign tumoral proliferation of bone are the mandibular giant cell granulomas. Mandibular giant cell granulomas of the jaw are more frequent in individuals with Nf1 than in the general population. Here you see a publication studying a mandibular giant cell granuloma of the lower jaw. Here you can see that the granuloma is affecting the bone and leads to a net resorption of bone. You can also see it here, the bone resorption. You see here the granulomatous tissue. This granulomatous tissue consists of fibroblastic-like cells that are in fact osteoblasts and multinuclear giant cells which are osteoclasts. Analysis of the resected granuloma tissue showed a second hit in the Nf1 gene, so a biallelic Nf1 inactivation in the osteoblast-like cells. It is hypothesized that osteoblast-like cells with a second hit in the Nf1 gene have a more immature biology and form less bone. And on the other hand, they secrete some local cytokines that attracts osteoclasts and hyperactivates them, resulting in a net bone resorption. Here you see a publication from the group of Juha Peltonen from Finland. They studied X-rays from the mandibula and maxilla in a number of patients in 29 women and in 26 men with neurofibromatosis type 1. And they showed periapical cemental dysplasia only in adult women with NF1, but they could not find a case in males with NF1. We believe that this periapical segmental dysplasia might be a minor manifestation and is comparable to the giant cell granulomas that I presented in the previous slides, and that this periapical segmental dysplasia is only a minor feature of this more severe giant cell granulomas of the jaw. Now I would like to present some data on skull defects in individuals with neurofibromatosis type 1. In this elegant study from Nikki Ulrich from Boston in 2013, 416 NF1 children were studied with imaging. They found sphenoid wing dysplasia in 15 of the 416, but also calvarial skull defects in 12 individuals. They also found 6 of these 12 with a calvarian defect to have a sphenoid wing dysplasia. So there is overlap between the two. But it shows that at least 3% of children with NF1 have a skull defect, as you can see here, and there also. And here you see it in a patient diagnosed at the age of 8 years, and here later on at the age of 17 years, where the skull defect has enlarged. So it might be a progressive condition. Here I present 2 individuals from our own neurofibromatosis clinic. And you see that the patient on the left side here has a bone defect here at the back of the head in association with a plexiform neurofibroma overlying the bone defect. You can also see it here on this 3D reconstruction, which was made because of cervical scoliosis that is needing treatment. On the right-hand side, you see an encephalocele here in the occipital region because of a defect here in the occipital bone. Glomerus tumors of the fingertips are also part of the phenotypic spectrum of neurofibromatosis type 1. They're more frequently observed in females than in males, and they are little tumors localized to the distal phalanx of the finger, and usually nothing can be seen by inspection. Sometimes a glomerus tumor can be associated with an abnormal nail, as you can see here, or with a little reddish discoloration, or a little swelling, as you can see here and there. And here you see the swelling, the discoloration, and a dystrophic nail at the same location. But again, usually you don't see any abnormalities at the distal phalanx. But these glomerus tumors cause localized pain at the fingertips, and the pain is very localized. It's usually worse in winter, and it improves when you heat up the finger. It is seen in 5% of adults, so the lifetime risk of getting one of these tumors is about 5% in adults, so it's more in females than in males, and it can be easily treated by surgical resection. A glomerus tumor is in fact a tumor of the smooth muscle cells of a vessel that is used for thermoregulation of the distal phalanges. When it is cold, the vessel will open and the blood will be short-circuited and will not go through the fingertip, as it is the case in the winter, and in the summer when it's hot, the vessel will close and it will force the blood to flow through the fingertips so that the individual can lose some heat through the fingertips. But when these smooth muscle cells that surround this blood vessel form a tumor, and then the blood vessel opens, then the blood that flows through the vessel will, together with the tumor, cause pressure under the fingernail, between the fingernail and the distal phalanx, and cause a lancinating pain. Analysis of these glomus cells has shown that they also have a second hit in the Nf1 gene, and that these tumors are an integral part of the Nf1 phenotype. It's very important to recognize this and also to ask the individuals if they have any pain in the fingertips, because there is usually no neurofibroma or nothing else to see, and adults usually do not connect pain in the fingertips to anything that has something to do with neurofibromatosis type 1. Professor Glorieux will now continue with the clinical aspects and treatment of dystrophic scoliosis and tibial pseudarthrosis.
Spine deformity in neurofibromatosis type 1. I'm going to present you aspect, evolution, and possibility of treatment. There are many problems to explain why a deformity occurs in Nf1. We are going to present each of them. The bone is dystrophic because there is a Ural Ecasia, and probably the neurinoma can be responsible. You can observe the scalloping and the very thin ribs. The curves are short, and the sagittal deformity, the most present is kyphosis. The rotary dislocation can be the most important deformity, and it is very dangerous for the cord. Ural Ecasia is probably the main explanation of the dystrophy. It is a problem because you will observe loosening of the bone, and after surgery, loosening of the graft. The neurofibroma are present into the canal, around the canal, or like on this CT, into the thorax. The quick evolution of the deformity is due to the dystrophy, and we can observe there an evolution in 2 years. We learn with the academic presentation that it was necessary to do early surgery with anterior and posterior fusion and graft revision. Look, the very quick evolution in this girl, which is very young. We performed an anterior and posterior fusion with a good correction of the curve and the balance. 2 years later, recurrence of the deformity under the fusion. Bad evolution 6 years later with important imbalance and pain. We performed an extended fusion by a posterior approach, instrumentation, and fusion. For this boy, we made a complete surgery at 11 with anterior and posterior fusion, but too short. At 20 years, you can observe the rotary dislocation, and he had pain and neurodeficiency. After allotraction, we performed a posterior fusion with good results on the pain and neurologic evolution. He is now 27 years, but the evolution is not so good with neurologic problem because of the Ural Ecasia. Our present approach is to prevent progression, keep a good balance, try to reduce dystrophy, and prevent rotary dislocation. This girl had an anterior fusion only 4 years ago, which was not able to control the evolution, which is very, very important. After 1 month of traction with Allo, we correct a little the deformity to prepare a posterior surgery. The surgery was done with 2 points of fixation, proximal and distal, with 1 rod under the skin. Here is a postoperative aspect. You can observe that it is a severe neurofibromatosis with cutaneous neurofibroma. You can see the 2 cutaneous approach. The balance is not so bad. 2 years later, she came back and we complete with the second rod. Look at the evolution of the face. 9 years later, she came back with back pain because the rod broke. She was operated on. We complete the device and she had a new graft. Here is the aspect at 20 years. We made the revision of those cases. We made 18 patients. And we can say now that with this approach, we can prevent progression. We can keep a good sagittal balance. The dystrophy seems to be controlled, perhaps because of the distraction. We can prevent the rotary dislocation and the chest function stay stable. Cervical deformity is frequent. This case is a boy that I saw at 14 years, but I saw him at 3 years because the deformity was at the beginning. He was lost of follow-up. Look to the aspects with the left upper limb, very typical, the spine cervical deformity. It is, I think, at this time impossible to do something without big risk. For the boy, he came for observation of abnormality of the right clavicle. We made X-ray control of the cervical spine, which was kyphotic, with very important dystrophy, and the MRI showed a big neurinoma. The deformity is probably because of the dystrophy and of the neurinoma. We perform a gradual reduction of the kyphosis with Allo. We want a posterior approach with excision of the neurinoma and a posterior fusion. The second time with an anterior fusion with a tibial graft was done, but we forgot to make the proximal fusion. After 1 month, after immobilization removal, he had the recurrence of the deformity and neurologic problem. So we perform an occipital-cervical fusion with a good results. Our last case is a girl with a huge thoracic neurofibroma with the aspect of the trunk, which is not so bad, with a flat back, and you can observe that the left cervico-thoracic deformity. The radiologic aspect is very important deformity, cervical kyphosis, thoracic lordosis, and scoliosis, and the ribs were very thin. The CT show a very big neurinoma in the left thoracic cavity. We perform an instrumentation without graft with proximal and distal fixation, but the deformity continues with a junctional kyphosis, and we made a proximal fixation. Spine deformity is a big problem in neurofibromatosis type 1. I'll show you the case with the most important problem. But you can understand that for the future, it could be a real challenge. Thank you very much for your attention.
In Nf1, congenital pseudarthrosis or congenital curve are the main presentation of limb problem. The leg is the most important location, but forearm can be affected.
The treatment of congenital pseudarthrosis of the tibia remains a challenge, with many procedures described, and results we are very varying. Example of a case of congenital curve with important dystrophy and anterolateral curve. The dystrophy, which is a condensation, broke, and 7 surgical procedures was necessary to obtain these results.
Our main old technique was the tibiofibular graft and nail. On this example, the dystrophy is very distal and important. The nail gives the alignment. The foot is included because the distal part is very small, and the graft is between tibia and fibula. You see, after 7 years, the results not so bad. But a new fracture occurred because the dystrophy stayed. New osteosynthesis with intramedullary nailing and new graft. the consolidation was difficult to obtain. And you see that after more procedure, the fusion was obtained with a nail, but the foot is included and the functional results not so good.
Another approach is to use external fixation and intramedullary nailing, but it is an EVE procedure, very long, and the results are not better. Vascularized fibular graft is a very demanding procedure, and it is not possible to use easily a central nail to protect the bone. Our actual technique comes from Alain Charles Masquelet with the principle of the induced membrane. We made the description of this technique.
The principle is to remove all the dystrophic part during the first surgery. One of the main problems is that there is no periosteum around this bone. The osteosynthesis is made with intramedullary nailing, and a spacer of methyl methacrylate is used into the bone loss. Here is the post-operative results with the K-wires, which can be telescopic, the fixation of the fibula, and the spacer, which go from the tibia to the fibula. After the operation, we applied a cast, and 2 months later, the children go back to the operating theater to make the graft. Here is the approach, and you can see the methyl methacrylate. It is removing, and you can see the 2 extremities of bone, the nailing and the induced membrane, which have capacity to obtain a good fusion with the graft. The graft is taking on the pelvis, and you can see how it is into the bone loss.
On this example, you can see a very important dystrophy, a short distal part of the tibia, and the results after the first stage, removal of the pseudarthrosis, osteosynthesis, and spacer. The cancellous bone graft and the fusion, which was obtained after 4 months. 2 years later, good fusion of the tibia with a small anterior curve. After 6 years, the tibia is nice, but there is a shortening as usual. Another severe case with an important distal dystrophy after the first step. The fusion is achieved at 6 months, and look to the growth of the tibia.
And the fusion is very nice.
Very nice results at 7 years. Sometimes the correction of the curve can occur alone if the dystrophy is not too important. A brace protection is very, very important, as in all our treatments for
those cases. You can see at 4 years, the correction is good because the growth plates are effective and the dystrophy is small. At 8 years, and you see the clinical results. Protection is always necessary and needs to be long. Resection, graft after induced membrane, seems to be a good technique, but this situation is always a challenge.
Hello, everyone, and welcome back. Thank you, Eric and Christophe, for this very interesting lecture and very detailed examples. We have a few questions coming in from the audience. The first one is from Eva Trevison, who asks, how frequent is pseudoarthrosis in bones other than tibia, as for example in ulna?
It is very infrequent. It's only 1 in 100, while in the tibia, it's about 5% of all Nf1 children that have either bowing and or pseudoarthrosis of tibia or fibula. But in the ulna, it's several times less frequent.
Then another question from Armel Pindon, who's actually been partly answered, I think. Is there any treatment using a biomorphic agent or anabolic agents applied to the surgical site of fracture repair in children with Nf1? Does Christophe wants to answer this question? Christophe, I'm afraid you're on mute.
Just can you repeat the question, please?
Yes, of course. Is there any treatment using a biomorphic agent or anabolic agent applied at the surgical site of fracture repair in children with Nf1?
What do you call biomimetic?
Biomorphic agents or anabolic agents, agents that...
I don't understand what is it.
I suppose
something like bone morphogenic protein, BMPs.
Okay. So it was used, I think 10 years ago, there was the try to do that. And it was not useful. And it was the time it was 15 or 20 years ago. And it was the time we begin with the technique with induced membrane. So we do not want to use BMP into those cases because we thought that the growth factor were present into the induced membrane and into all those things. And in children, at this time, we didn't like to use BMP because there was other problem with this support.
This actually opens up a question, which is because from your presentation, there is a lot of surgery with bone issues in NF1, and I wondered if you could give us some insights into other types of therapies that are being developed at the moment, or if surgery is the one and only option at the moment, and other things are not really being explored.
Unfortunately, the evolution for the spine, if we are going to speak about the spine, unfortunately, the evolution of the spine is not always the same. In the beginning, we use always bracing, and we try to stay a long time with the bracing. But sometimes you can see in 6 months a deformity which is around 50 degrees, who come to 80 degrees with rotary dislocation. And at this time, it is very important to try to control, and there is not other solution than the surgery. And we think now with the posterior fixation only, like that, we can wait and we do more surgery, but before there was many surgeries. So
thank you. Another question still on therapies from Armel Pandon. Should chronic vitamin D deficiency in Nf1 patients be systematically addressed?
This is a good question. I don't know, to be honest, and I don't know if supplementing with vitamin D will have a strong effect on bone mineralization. It has been shown that there is a relationship between Nf1 and vitamin D deficiency, and there's also been demonstrated that there is a relationship between the number of cutaneous neurofibromas and the level or the low level of vitamin D. So it's an inverse relationship, but it has never, according to my knowledge, been shown that chronic supplementation improves the condition of someone with Nf1. And these are studies that should be done, should be undertaken to see if it has any effect at all and what the effects are. But it's a very good question, but it is, according to my knowledge, an unsolved question at the moment.
Thank you.
Exactly same approach. We don't know, but I have one surgeon in my team. We use always vitamin D, and we can say, but I think today it's impossible to say.
Thank you. A question from Luigi Barlassina. How often the difference in leg length needs to be reviewed? And at what stage do you intervene with insoles and when surgically?
You think of the lower limb discrepancy?
Yes.
Yes. It is a problem because lengthening is quite and normally not recommended to do at the end if you obtain the fusion. So the only solution is to shorten the other side, and we use what we call epiphysiodesis, and we can have around, it's possible to have 4 to 5 centimeters if you stop the growth of the other bone at the age which is okay for this length.
This perfectly corresponds with what we found, that in the case of pseudarthrosis, where you perform surgery and you have access to tissues above and below the pseudarthrosis site, that also there, this second hit in the Nf1 gene is present. So as soon as you have fusion, then I perfectly understand that as a surgeon, you don't want to touch that bone anymore, because you know it's very fragile, and even above and below the pseudarthrosis site itself, it is not going to heal as easy as a normal bone. And therefore, I think it's a perfect attitude and approach to then target the other leg instead of the one where you have done so much, you have invested so much energy to get fusion, and then you don't want to touch it anymore. I think that's a perfect strategy.
Thank you. A question from Simon Perrin. What are the local factors causing pseudoarthrosis development additionally to the Nf1 biallelic inactivation?
I think that's a question for me because I alluded to that. In the prenatal period, there is some stress on the tibial bone because of the position of the lower limbs in the womb. So there is always a little bit of bowing of the tibia due to the positioning of the legs. And in case of a second hit in that lower leg, there is the bowing is specifically targeted to the lower 1/3 of the leg because it's less strong and it bows much easier than the rest. So the prenatal positioning is of importance, and also probably some factors that are associated with blood supply, because it seems to be that the region of the pseudarthrosis side, but Professor Glorion can better comment on that, is a kind of a watershed area where two vascular supplies end. And also the vascularization of that region is less important, and there are, or less present. And there are probably some other aspects that we don't know yet that also might play a role in the local bone homeostasis, but it seems that the second hit itself is necessary but not sufficient to cause the bowing and the pseudarthrosis. And of course, there are also other bones in the region where you, in the skeleton, I mean, other bones that should have a second hit during development, but where we never see a pseudarthrosis. So second hits are not limited to the tibia and the ulna, but are also present in other bones where we never see any problem. So it's not only the second hit that causes the bone problems, but also some local factors. And I just summed a couple of those that we know, but there are probably many others that we don't know yet. So there is still a lot of potential research that has to be done by young scientists.
Thank you both. We have another very long question, which I'm going to try to resume from Claudia Santoro, who stresses on the importance of natural history studies and wonders if if you think that the natural history could change thanks to the selumetinib treatment in those with a concurrent adjacent plexiform, and can we expect a lower growth rate of the bone, for example?
I showed this one case that was influenced by treatment with selumetinib, and I think that this should be further studied. This is only one case, but it is quite illustrating. And by treating plexiform neurofibromas with selumetinib, especially those that are located close to the bone and are affecting bone morphology and bone mineralization, I think it's very important that future studies in children who have these type of plexiform neurofibromas also pay a lot of attention to the adjacent bone and not only focus on the volume of the plexiform neurofibroma. I think it's a very good question, and we should all, in the future, when we start treating patients with selumetinib, once it is a standard treatment, we should all look at this and gather the data from these studies to see if it makes a real difference or not.
And as far as you know, are data regarding bone abnormalities being collected at the moment in the various selumetinib trials around the world?
I'm not aware of that. I know of all the volumetrics that they do on all the patient-reported outcome measures. And I know of a couple of studies who are also looking at the cognitive and behavioral aspects, because we also believe that the increased MEP kinase pathway has an effect on behavior and cognition. But I found only this one study where they looked at bone. So I think that these people who publish this will also look at all their other cases, that they have to see if there is an effect of treatment of the plexiform neurofibroma and trying to diminish the effect of the neurofibroma on the adjacent bone. But this is something that has to be studied in detail. And since it's so important that these studies are done, I introduced this slide into the slide presentation.
Then we have a question which I assume to come from a non-medical professional, a question from Svetlana Volgina. I would ask you to speak very slowly, because I think your question needs to be very well translated into Russian for this person. and she asks, how common is what age should surgery be performed for scoliosis? How common is the progression after surgery? Is it necessary to have an operation for severe scoliosis? And what kind of rehabilitation exists for scoliosis in children who can't be operated?
So it is not always the same, but we can say that for the surgery, we can begin after 5 or 6 years. And before we, as I show you, we try to do in one shot with 2 big operations and try to obtain a result. And it was not always. So now the program is progressive, and we know that we will have 2, 3, or 4 surgery. Again, the surgery is not always necessary, because in neurofibromatosis, there are 2 kinds of scoliosis. They are dystrophic, like we show you, but sometimes you have scoliosis with no dystrophy, and the evolution is like an idiopathic. So it is not always, which is important. It's to see in the beginning how is the bone, do an MRI to see if there is dural ectasia and neurofibroma, and after have a short follow-up. I think that after 6 years, each 6 months, you need to have a control. And if you see a quick evolution, a control, and you have to control the deformity with a brace if it's possible. And if you have an evolution, it depends how it's important, but you can begin the surgery. And for the rehabilitation, with our technique, it is not a very long time. It takes around 1 month to 1.5 months.
Thank you, Christophe. We're almost at the end of our webinar. There are no more questions from the audience at the moment, but I have a burning question, and that is how systematic is the monitoring of bone issues in Nf1 patients? Eric?
Yeah, this monitoring is basically a clinical monitoring, meaning that a child that comes for its checkup will be examined for discrepancy in leg length, will be examined for bowing of the limbs, will also be examined for scoliosis. And we see children on a routine basis every 6 months, others see children every year, but I'm always surprised that in certain cases, the scoliosis is very progressive, where you start with a normal looking back and 1 or 2 years later, it might be already quite pronounced. So it is important that young children with NF1 have regular clinical visits where the skeleton can be ascertained by clinical examination, and in doubt, X-rays have to be taken. But there is no, as far as I'm concerned, reason to do specifically X-rays when the clinical examination is completely normal. So no need for screening by X-rays, but only screening with X-rays when there is a clinical suspicion.
Well, thank you both very much for your very thorough answers, and to the whole audience for the very nice questions. The webinar is now about to finish. I want to thank everyone, especially Eric and Christophe, for being with us today. And I hope to see everyone very soon on our next webinars. Please check our website, which is regularly being updated with new webinars. And please also check on the website, you will find a link to the Info YouTube channel, where all past masterclasses are visible for anyone in all 7 languages. Thank you, and hope to see you soon.